Well, welcome back. I'd like to spend some time this morning just having an opportunity for you to debrief with another person on the homework. So up here, I have a couple of guiding questions to, if you want to break up into groups of 2 or 3, just to have an opportunity. You don't have to disclose what you rated yourself on these attitudes and values. I'd just like to have a little bit of an exploratory discussion on them. So just some questions before you break off into small groups. What additions or deletions would you make to the list of attitudes and values? Did you go through and find that there were some things that were missing? Or did you go through and find that some things just didn't seem very applicable? How difficult was it for you to evaluate your own behavior, and were you surprised by the results? Sometimes when we take time to do self-reflection, it's not something that everyone does typically on a day-to-day basis, so sometimes we can be surprised at what it is that we find. And then how accurately do you think the observable behavior reflects a person's attitudes or beliefs regarding working with individuals with co-occurring disorders? And you can even expand this a little bit to think about observable behaviors of other colleagues and professionals that you work with, and kind of discuss or explore if you think that you have a pretty good grasp on where people's attitudes and belief stands related to the work that you see them do day in and day out. So before we get started on the module, I just want to make sure that everybody has these at the ready when we get to them. So you should see the DAST, and then something that looks very similar to that called the MAST. And then there is actually a scoring sheet for the MAST. So screening. Screening for substance use disorders and mental health disorders. So we want to describe the purpose of screening, evaluate the methods for screening, learn about the screening tools to be used in mental health settings and substance use treatment settings, and we're going to get some practice using some of these screening tools. So before we get started, in small groups, break up, and I would like you to discuss these questions. So in your current practice, what methods do you use to evaluate if a person has the potential for a substance use disorder and a mental health disorder? How reliable do you think your methods are at recognizing the possible presence of a substance use disorder and a mental health disorder? What are some of the concerns you have about screening for substance use disorders and mental health disorders? And what is your current level of comfort related to screening and assessing for substance use disorders and mental health disorders? And that's actually something that's very common, is that it's very clinician driven. So if a clinician is comfortable or has experience doing a thorough substance abuse evaluation, you'll see that a lot of times in their narrative reports, that section is very lengthy. For others who really hadn't received any training in it or are uncomfortable with it or just don't see it as necessarily relevant, their narrative can be just 1 or 2 sentences and doesn't really have the detail, like you were saying, as far as family history, personal history. So maybe they're not using substances now, but they also have an extensive 30-year history that could actually be clinically relevant at some point. So very clinician dependent is where a lot of people are with the screening. Right, and that actually speaks to what a lot of people will say is, I'm not going to screen for it if I can't treat it. So if I can't do anything about it, I don't need to know about it. So I'll ask the general question, but I'll also hope that you say no, and we'll be well on our way to completing the remainder of my assessment. Even physicians, even primary care physicians, have to screen for tobacco use and alcohol use and depression. Those are the 3 major ones that most are required to do, particularly if you get federal funding. You're supposed to be doing a depression screen and a tobacco screen at least. So for nursing, one of the key components that they have often said is that their screen, their standardized screen, is the UDS. And that's it. And the one at NAMS used to be just a question of, have you ever been to AA or NA? So they're in the process of retooling their nursing assessment to actually use some of these standardized universal screens. And you want the work that you're doing to actually have some usability to it. Like, how applicable is this really? So I'm going to spend a half hour with this individual collecting all of this information to put it into the medical record. where it will go into archives forever and ever, and no one will bother to look at it, read it, and it's not really being integrated into anything else. And that, I think, is a great reason why screenings are very important, is because you can actually begin to collect some of the additional information that can help with diagnosis, but also raise some flags to say, we need to have a level of curiosity here, because it seems as if something is going on, particularly if there is inconsistency in reporting across the professionals that are meeting with this individual. And sometimes that's based on just level of comfort. So I'm going to believe that you're going to want me to say no, so I'm going to say no, but I feel comfortable with you, maybe because your approach is a little bit different, so I'm going to say yes. So if it's in the medical record and nobody has actually put the pieces together to say, here they've denied it, but here they've admitted it, and now we need to do a further assessment, where do we take them, how do we get them there, that can lead to all sorts of misdiagnosis and mismanagement, particularly when we're looking at symptom management. So if they've denied to the psychiatrist and whoever did their intake that they've been using drugs, and then the nursing assessment finds that they've been using methamphetamine, that's important information to be able to share as a team to really help parse out what are the symptoms that we're seeing and what can we attribute those to. If we really truly believe that recovery is possible and people will get better when they're given effective treatment, the diagnoses don't necessarily have to stay the same over time. Now, clearly, if someone has a chronic, serious, and persistent mental illness, we might get a more sharper focus as to really what does this diagnosis meet criteria for. And we know that for things like schizophrenia, there isn't really a cure. People aren't necessarily going to recover and no longer meet criteria for that diagnosis, but their quality of life could improve, certainly. They could go into remission for some of their symptoms, particularly some of the more positive symptoms. So I think that you're right, things do change. And when you have someone coming in to treatment from being in a controlled environment and just chalking that up is, full sustained remission, doesn't really work. You have to have the qualifier, the specifier around in a controlled environment, because now that they're no longer in a controlled environment, if they're just seen as sort of fully on their way to recovery and no relapse prevention is being provided, the person is often going back into, they're re-entering into society to the same people, places, and things that were typically triggers for their use to begin with. And if we're not helping them to address those or be aware of those, their chances for relapse are relatively high. Because you've taken them from an environment where the substance that they were choosing was no longer available. And maybe they did receive treatment, but that continuity of care is very, very important. So we see reentry, especially the first 90 days of reentry after being in a controlled environment, incredibly important for helping someone maintain sobriety, which really over time is an essential piece for that continuous assessment. So those are very, very valuable data points. Was there anything else that anybody else wanted to share around screening? Either the usability of them or the use of a standardized screen. Remember yesterday when we went over the dual diagnosis capability toolkits, the requirement for being capable is to have a standardized, formalized screening assessment available. So functionally impaired, or we forget that they don't necessarily know how to read, handing them a paper pencil screen or any type of assessment to fill out is not going to be effective. So I'm not necessarily proposing that we would give these directly to patients. And I'm not saying that we would do it right off the bat. What I am saying is that there's a difference between what we call a universal screen and an indicated screen. What we're going to go over in a minute, the papers are really more of an indicated screen. The universal screen that we talked about yesterday is everybody gets it. Everybody gets it. And it may be asked in one place by one person all of the time, or it is asked by a group of people. So it's embedded in the nursing assessment, it's also embedded in an intake assessment, and it's also embedded in the psychiatric evaluation. So each agency and each program really needs to figure out for themselves workflow and who makes the most sense to ask the universal screening tools, and then make sure that everybody has a training on them and sort of what do you do when you get a positive screen. I know for some of our rural clinics, for the outpatient, for example, the community health nurses as well as the psychiatric nurses will be using the universal screens. And then each clinic actually has to do some problem solving to figure out when there is a positive screen, who does that information go to? Does it go to the psychiatrist for further assessment? Does it go to a clinician for further assessment? But where is it going to fit into the workflow? And that's an important piece that is often missed, is that, okay, great, we've got this package of tools that we're going to use, so let's use them. But the usability plummets because it's not fitting into anyone's workflow. And then it's, well, I thought you were doing that. Well, no, I thought you were supposed to do that. And so it either doesn't get done, or the same person gets the same question asked by 3 different people on the same day, which is also equally very frustrating. So we have to really work to figure out what the workflow is. So some of the myths around screening, and I love Mythbusters, it's just one of my most favorite shows ever, because I think that we often walk around with a lot of myths around a number of different things that we do or do not do. And so it's always fun, I think, to bust some of those myths. So some of the myths around screening, screening and assessment are no better than intuition in detecting a person's need for treatment. Objective screening and assessment measures can result in treatment that's better targeted to a client's needs, resulting in better outcomes. Would people agree with that? Okay. Only a single screening is needed to place people in different levels of treatment services. No, absolutely not. Our universal screen is really just a yes/no to detect, is there the potential, is it highly probable that a use exists? Is there use or is there not use? If there is a no, we want to know that. But there's no real specificity to a yes/no. We can't tell how severe or how risky the use is related to just a yes question. So we have to probe a little bit deeper. So an accurate evaluation requires a battery of instruments to examine how substance use has affected all the domains of a client's life, which is essential when we're going into the diagnostics, right? Particularly for substance use disorders. We have those new 12 criteria that we need to be looking at. So we need to know historically and currently, how has the use affected or impacted this individual's life? Untrained professionals cannot conduct screenings and assessments. Although some screenings can be administered and scored without significant training, placement decisions are greatly improved when they're made by professionally trained staff. The idea here is that you train the individual on how to actually use the screening tool with some fidelity, so that people are doing it in a way that is consistent across the people who are doing the screening tools. Some actually require advanced professional degrees, but not all. Myth: if an individual has a positive screen for a substance use disorder, the clinician is responsible for treating the substance use disorder. Likewise for a mental health disorder. So we talked about this myth earlier, where everybody was saying, you know, if I have to screen for it, then I have to treat it. And that's not necessarily true, because if you can coordinate treatment under the care of another professional, that can go on your treatment plan. So if you screen and you detect and you diagnose that there is a substance use disorder, and you have adequately linked and are coordinating care with another professional, because maybe it is outside of your scope, that's sufficient to have on a treatment plan, because at least you've acknowledged it. It's much better than having it on the axes and not having it addressed at all on a treatment plan. That, when it comes to compliance, is a real challenge, because if you've identified it as a problem, you need to figure out what you're going to do about the problem. But coordination of care is certainly sufficient, especially when you don't have the capacity within your program or your agency to provide that level of care or treatment. If a client has a substance use disorder but the clinician doesn't feel qualified to provide treatment, the diagnosis should be left off the diagnosis list and off the treatment plan. No, that's just like when you have mental health clinicians say, well, I always leave Axis 3 blank because I don't diagnose medical conditions. Well, that's true, you don't diagnose medical conditions, but it is a 5-axial diagnostic profile, and if they are coming in and self-reporting that they have diabetes or COPD or anything else, you need to list it, and you can certainly, if you are more comfortable, put in parentheses by history or per patient report. But really, we need to make sure that if the diagnosis exists, it's listed, because you may know that it exists and it's not on there, but nobody else will. And if someone is non-compliant with treatment, they're lost to follow-up, they're a complicated case that doesn't seem to be getting better regardless of whatever kind of care we're providing to them. That's an essential piece of information that really needs to be part of the medical record. So having all of the information that's available accurately reflected in the medical record is an essential piece. Okay, so screening 101. We have reliable and valid estimations that there's a greater likelihood that an individual has a substance use disorder or a mental health disorder than not. That's really what the screen tells us, is that there is a greater likelihood for a positive screen that there is a substance use disorder or a high risk of use. So a positive screen does not result in an automatic diagnosis, right? So you're not going to do a universal screen and then say, oh, this person has a substance use disorder, because they may just be high risk, like we talked about yesterday when we talked about the public health model. And that really we also want to be probing a little bit more, because if it is risk, but it doesn't meet criteria for a substance use disorder, we can provide that brief intervention. We can provide some psychoeducation. We can actually do something to prevent it from becoming a use disorder. So for screening protocols, they want to alert the clinician that further assessment is necessary to determine the severity of the substance use and if the use meets criteria for a substance use disorder. Likewise, if there are mental health symptoms that are known and they come out as a screen, so that the clinical staff can then probe deeper and figure out, does this actually meet criteria for a disorder? Screening protocols also are necessary to describe the formal process in place for an individual with a positive screen to receive a more comprehensive diagnostic evaluation. And that's really what I'm talking about when it comes to workflow. So every program, every agency really needs to figure out where does the information go to make sure that if a positive screen is there, that further assessment is needed. Just like if you go into your doctor's office and they take your blood pressure and you have high blood pressure, they're going to note that you have high blood pressure, but chances are the physician that comes in is then going to evaluate further what's going on. Why is your blood pressure through the roof? So further assessment is necessary. And screening protocols also provide a standard for documenting findings on the screenings and the outcome from further assessment, and that professional obligations by each staff member has been met. So along with workflow comes responsibility. So if in the workflow, in the process, my responsibility is to do the universal screen, and then my responsibility is to make sure that you are supposed to go to wherever else the procedure tells me you have to go if it's positive, then I've done my due diligence, I've gotten the warm handoff, I've followed protocol. Now the other person picks up the responsibility to figure out what they're supposed to do with the rest of that assessment. So that's why we have screening protocols. Okay, so you have a protocol, because taking a temperature is a screen, right? Is the temperature elevated or not? Really, it's kind of a yes/no. It's a dichotomous question, right? So then based on a yes, then there's a protocol that's in place. What do we do with that? And then the nursing staff knows exactly, this is what I'm required to do now by protocol based on this. And if it's elevated to a certain level, then you probably have a different protocol to use. Well, it can be helpful because in the absence of a person available to ask the question, what do I do next? It needs to be spelled out somewhere, right? So that everybody can interpret it with some consistency. So it's not person-driven, it's not clinician-driven, but it's consistent because it's procedure-driven. Okay, so the clinical process, the universal or pre-screening, then the indicated screening, the assessment, and then the treatment plan. This is kind of the basic clinical flow. So everyone is screened with a universal screen. Time intervals for screenings are predetermined. So typically it could be upon intake every 6 months or annually. There are certain guidelines even when it comes to tobacco use screenings as to how frequently those need to be done. We want to make sure that there are intervals so that, just because at intake someone said no or, didn't have a positive screen doesn't mean that they're never screened again. So there are ongoing screenings based on delineated times. They're typically brief and very easy to use, and a positive screen typically requires a more lengthy and structured screen, which is the indicated screen. So the NIAA 3-question screen for alcohol use. It's very popular, it's widely used, it's out in the public domain. Many medical facilities will use this as their screen. So basic question, how many days per week do you drink alcohol? Not do you drink, right? But how many days a week do you drink alcohol? It's a totally different wording, gets different results. On a typical day when you do drink, how many drinks do you have? This is also going to give you an idea of, is the individual consuming alcohol at rates that are sort of excessive, or is it within sort of the normative limits? And what is the maximum number of drinks you've had on any given day in the past month? This will also give you an idea of, is this individual binging? So maximum drinking limits for healthy men up to age 65, no more than 4 drinks in a day and no more than 14 drinks in a week. For healthy women, that's maximum drinking limits. This is indicative that there's a max. Oh, yes.
And is it a tumbler or is it a shot?
Well, and so there are great tools. Actually, I brought, so here's how this will work. Is this it? This is it. Okay. So remember yesterday I talked about screening and brief intervention, right? So we're bringing screening and brief intervention to Nevada. It's a very wonderful thing. Part of it is determining which formalized universal screening tool we will use. So once that has been chosen, then we develop a protocol. And then we distribute materials so that clinicians have them at the ready, because this will increase the usability of the tool for everyone. So this was developed actually through the FASD Training Center. And this is what they use when they're training clinicians on screening and brief intervention in medical settings, particularly OBGYNs in primary care, anyone that's involved in family planning. So that the question is right there and it gives you your screening results. So it allows you to figure out, okay, 12 ounces of beer, 5 ounces of wine, 1.5 ounces of liquor, all of these equal a drink. So it gives you the metric right there, so you can actually have the conversation with the individual. And then it gives you normative amounts of what you need to be aware of as far as risky use or the potential for a substance use disorder. Okay?
Does this tool progress, to, have you ever had blackouts? What are the problems? No. I mean, this is just the simplistic form.
This is just the universal screen. This is there potential for
blackouts, seizures,
right, all of that. No, that's the indicated screen. So now we have a positive on this, and now we have an idea of how risky someone's use is. Then we know that there's an indication that we need to do some further assessment. So that's either the indicated screen or a full assessment. The cool thing about this is, for those of you who will be taking screening and brief intervention, it also has a nice little pocket guide on the various types of brief intervention that you can provide. So it gives you all sorts of prompting questions like, provide feedback. I saw you completed the screen. Is it okay if we look at this and discuss the results? And then it also has this readiness ruler. I just want to point it out to you because it's a really nice tool about exploring change and asking individuals, how ready are you to change? How confident are you in your change? And how important is it for you? 3 very important dynamics when trying to figure out, what am I going to do with this individual as far as interventions go? So engaging with them on meaningful conversation, because you don't know, is it lack of knowledge? Do they know that it's dangerous to mix these? Or is it that they have really lost control over their consumption and they're consuming more than they had anticipated? They have tolerance, they experience withdrawal. That's where the assessment piece comes in, because those pieces are essential. And when you look at the ASAM, which is what clinicians can also use, we're looking at what is the potential for DTs and serious adverse events to happen when someone is withdrawing. What is the history of those withdrawals? So that is part of the package, hopefully, of all the information that will come out of just one screen. Okay, and then the NIDA single item drug use. How many times, again, not do you or have you ever, but how many times in the past year have you used an illegal drug or used a prescription drug? Don't repeat the second line, that's a typo. A prescription medication for non-medical reasons. Okay, so how many times in the past year have you used an illegal drug or a prescription medication for non-medical reasons? Yeah. So here, really, you're looking at a positive screen as one or more. So there was a day in the past year that I have used an illegal drug or a prescription medication for non-medical reasons. If someone says once, we know that we're going to look a little deeper, either with an indicated screening tool or a fuller assessment. And they also have these for adolescents, and this is actually normed for individuals up to age 21 years of age. So one of the populations that is typically forgotten about is that transitioning adult population, 18 to 23. And there are some very specific tools that can be used to address that population. Here, it's a question around, during the last 12 months, did you drink any alcohol? So if they're under age 21, any alcohol is a positive screen. Did you smoke anything, any marijuana, any hashish? Did you use anything else to get high? If they answer yes to any of those questions, it's a positive screen. And then the PHQ-2. This is a basic screening tool for depression that many medical offices use. It's also very, very good for a brief screen, just to get an idea of, is this individual likely to have some type of depressive disorder? And so the two questions, very basic, are over the past 2 weeks, how often have you been bothered by any of the following problems? Little interest or pleasure in doing things, feeling down, depressed, or hopeless. And you can see here, they give you some really nice psychometrics. So if the score is 1, the probability of major depressive disorder is 15.4. But if they rate both of those nearly every day, they end up with a score of 6, 78.6%, the probability of a major depressive disorder. So when I'm working with our SAPTA providers, we're working to make sure that not only are they obviously screening and assessing for substance use disorders, but they're also screening and assessing for mental health disorders. Just like we haven't traditionally done it in our system of care, they have not traditionally done mental health screens in their system of care. And so we're also working to help build their capacity to be able to ask some of these questions and figure out what they're going to be able to do to further assess. So the indicated screenings should be valid and reliable measures. They have cutoff scores that are used. Sensitivity, so 2 terms that are usually used around describing indicated screening assessments. Sensitivity, it's the probability of the test being positive when the disease is present. Does that make sense to everyone? So it's sensitive. It's sensitive enough to detect that it's positive when a disease is present. And the specificity, the probability of the test being negative when the disease is not present. So we, what?
False positives.
Yes, exactly. It must be clinician scored and reviewed. Often the results can assist in guiding the assessment of specific disorders. So it's not used to diagnose specifically, but we can use it to collect information necessary for the diagnosis. I'm aware that not everyone in this room will be using an indicated screen because of the scope under which they work. But I do think it's important to at least have some exposure to them so that even if you're just the person that is handing off a positive individual who has a positive universal screen to someone else, to have an idea of what it is that they might be looking for, you may actually, because you're doing the screening, have an opportunity to ask some of these questions. That's information that could be very helpful to be able to pass on to someone else who's going to do a further assessment. So I think just having an idea of the kinds of questions that are on these screening tools can be helpful. Okay, so the MAST has been around for a long time, I believe 1971, and then it was modified in 1980. There have been some better screening tools, indicated screening tools that have evolved since then. But this was something that originally was recognized by the state as something that we would use as an indicated screening tool for alcohol screening. So this may not actually end up being the one that we really end up rolling out statewide, but it'll give you a good idea of the kinds of questions that are asked in indicated screening tools. So the great thing about it is it looks for lifetime alcohol-related problems and indications of alcoholism. It's a very general measure of a lifetime problem severity that can be used for choosing treatment intensity and guiding further inquiry into alcohol-related disorders. It can be used either in paper pencil, self-administered, or in an interview format. So what we're going to practice today is actually using it within an interview format to get you comfortable with asking some of these questions. Can take anywhere between 5 and 8 minutes to administer. It really just depends on how much detail the individual is giving you when you're asking the questions, and about 5 minutes to score. The DAST is a little bit newer, and it was actually mirrored right against the MAST. And so the idea here was that you would have an alcohol screening tool, and then you would also have a substance abuse screening tool that were essentially the same, except the focus went from alcohol to substances. They have a shorter version. They also have an adolescent version. But again, it's a general measure of lifetime problem severity, and it's really to help guide further inquiry and figure out if further assessment is needed and to help with some treatment planning. You can do it paper pencil as well, or you can do it in interview format. For the purpose of today, we're just going to try it in an interview format. How many of you are familiar with the new DSM-5 screening tools that they have? Okay, you are. What has your experience been with them? All right. What?
Not very accurate.
They're not very accurate. No, they're not. And they're not very accurate because they're not diagnostically specific. Essentially, the DSM-5 has come out with some exploratory tools, but I really like the level 1 cross-cutting tool instrument because it touches on the major domains of what they call cross-cutting symptoms. So they're not necessarily diagnostically specific, but it does touch on things like unusual perceptual issues, sleep, depressed mood, mania. And so what they do is they kind of cluster them, and then from there, there are diagnostically specific screening tools. So that you would go, if someone indicates that they have mania, you could go to a mania-specific screening tool. The reason that I like these is, especially in an outpatient setting, it's a good idea when someone is first coming in just to get a real broad overview of what kinds of things this person is really endorsing or experiencing. So it's really about that funnel of information, so you're sort of deducing down what is the actual problem or issue at hand. So it's a way to take that macro level of information and begin to start narrowing focus to where you think further assessment should be. So anyways, they're available in the public domain for free. They have systems for kids, adolescents, and adults. And they talk about cross-cutting symptoms. So there's level 1 screening tools, and then there are level 2 screening tools that are much more diagnostically specific. One of the reasons that these slides are in here also is because SAPTA providers have been present in the past for some of these trainings. And so this is also kind of helping them to gear up what other screening tools they could begin to use in their practice. The other thing is it does have a question on substance use, suicidal ideation, and psychosis. So even a rating of slight, which is 1 or greater, requires further review. And then the craft, again, we talked about the first 3 questions for adolescents, and it's normed up to age 21. There are additional questions that you ask based on a positive screen for those 3 first questions. And those questions are, have you ever ridden in a car with someone, including yourself, who is high or had been using drugs or alcohol? So we're really looking at some risk factors here. Have you ever used alcohol or drugs to relax, feel better about yourself, or fit in? Do you ever use alcohol or drugs while you are by yourself or alone? Do you ever forget things you did while using alcohol or drugs? Do your family or friends tell you that you should cut down on your drinking or drug use? Have you ever gotten into trouble while you were using alcohol or drugs? Obviously, not diagnostically specific, but really asking some of those probing questions to get a better sense of how problematic really is this in an individual's life.
More naturalistic language,
right?
Which is appealing.
Yeah. So it's actually one of the kind of gold standards for screening for adolescents. But that is a great exploratory question when doing an assessment, because you also want to figure out what stage of change is this person in. So if they're telling you that it's created all this havoc in their lives, but their first experience and every experience that they've had has been great, then you've got some dissonance there that you can work with. So I think that's a great question, though, because sometimes people actually have very pleasant experiences from using, and so they're not even considering to stop using because the amount that they use is just enough to keep them happy, or it's doing what it is that they need it to do, and they find that pleasant. As a healthcare provider or a mental health care provider, it's also our due diligence to provide that as a learning opportunity, but it doesn't necessarily have to mean that you say, you know what, you're right, I really need help now. It's not about that. Change happens in millimeters and centimeters, in the smallest of increments that sometimes we can't even see it. So maybe it's not that she's going to convince you to seek treatment, but she's going to take that as an opportunity to provide you some basic level information, education, and just let you sit with it and see if that changes your perspective in the least. But again, it's something that we want to be conscientious of so that we don't get caught in that whole, oh great, now I just told him everything was fine with his use, and now I'm painted into the corner because I don't have anywhere else to go. You do, and sometimes it's just a little bit that can get them thinking in a different way, and maybe not. Maybe it's the 5th, 6th, 7th time that you see that individual on the inpatient unit, and you've had the same conversation with them over and over again, but you know what? They're back again for the 8th time to have that conversation. And this time they're a little bit more open to it because the evidence has shown them that their behaviors, if they continue to be consistent, end them right back up into the same place that they found themselves in with you today. So sometimes we don't see the change for the seed that we planted, but that doesn't mean that it's not there. It's just like any other structured interview, right? So you're getting through the questions and you're collecting information, but you've also got this running list of things in the back of your mind that you're like, ooh, I'm gonna wanna come back to that later. Or, oh, this is an interesting data point. Something that came up in the back of the room was that there were 2 questions that are similar, and the individual gave 2 very different answers to those questions. So does that mean that the tool is completely invalid? Not necessarily, because you're still collecting information. So we're not gonna just throw it out the window. We're gonna ask ourselves, okay, how are we making sense of the inconsistencies in reporting? Is this something that we have enough rapport that we can ask a little bit more to clarify? And again, words are interpreted differently by different people. And so sometimes it's their interpretation of the question that leads them to an answer or maybe an inconsistency, where otherwise if you have an opportunity to dialogue and talk a little bit further, you can really get the gist of the information that you're looking for. It's very interesting information. And although this is, you know, done in a yes/no format, and if you're using it as an interview, you're asking the questions, you're certainly free to do some more exploring, especially when you hit a nerve and someone really wants to open up and tell you exactly what the answer is to the question, and give you some more information. And really all of this is to help generate a more accurate diagnosis. Yes?
Is there a graph that determines, you know, 0 to 10 is mild use?
So there are cutoff scores, and I realize that it's not on the MAST. So I will get those for you by the end of lunch so that you have those to write down on there. Okay, we're almost done. We're going to break for lunch. So some tips. You can always use the scoring tools when you need some guidance as to the questions to ask, and how to go about asking those questions. Remember to take a non-judgmental approach. It's not that you're sitting down trying to get all of the information necessary, because shame on you, you've been using, but that you really want to take that non-judgmental stance. Pay attention to the quality of your own thoughts and reactions. Those nonverbals are really good indicators that, yes, I'm listening, I'm with you, or this is a really bad problem. So pay attention to what it is that, how you're responding. Engage the client in meaningful discussion of the findings. So again, we never want to give someone a screen or an assessment and then kind of leave them hanging. Sometimes there's sort of that performance anxiety, like I want to do this well and I want to be open with you and be upfront with you and share this information with you. But if there isn't a summary at the end to really talk about what your findings are, you can leave the person feeling a little exposed. And then make sure that you have the recommendations. So what next? What can this person anticipate and why? So picking up right where we left off with screening. So step 3 of that 12-step assessment process, screen for and detect co-occurring disorders. And when we talk about co-occurring disorders, we don't want to forget that the co-occurring mental health disorder is also an important factor, as is risk. So we need to pay attention to the fact that we are also looking for risk factors. So suicidal ideation, homicidal ideation, medical complications, functional impairment or the ability to care for oneself, the severity of their presentation, domestic violence, all of the factors that are also going to need to be put into our locus evaluation. So how many of you are familiar with the locus? Just by a show of hands. Okay. Okay. And what is your understanding of what the locus is? Okay. So it's actually a fairly robust system to evaluate or assess for severity on 6 dimensions. I'm going to go into it in just a little bit, in much more in depth, but each assessment, the locus and the ACM, both have one specific dimension that is very focused on risk. So where the ACM, risk and biomedical complications as a result of withdrawal management or detox, is also a key point, locus has a whole section on risk of harm. So just to be mindful of that. Right now we use the locus at like the most minimum level it possibly could be. And when I go into explaining how rich the information that you could be using to complete a locus and how it could be used if we were actually using it to its fullest capacity, it would actually do a great job of minimizing as much duplication of documentation as we actually have when we do assessments. So we want to screen for acute safety risks, screen for present and past substance use disorders, and current and past mental health disorders. So step 4, determine quadrant and locus of responsibility. That's where this comes in. So remember that if an individual has a severe substance use disorder and a relatively stable mental health disorder, a referral to a substance use disorder treatment provider is indicated, mostly because they're the specialists in town that really work with individuals with acute and highly severe and persistent substance use disorder needs. That being said, as we talked before, someone may not be ready, willing, or able to engage in additional services or make use of a referral, so then we try to meet them where they're at and work with them slowly and encourage them at some point to engage with some type of specialty service. Quadrant 2 is for individuals with severe mental health disorders and less severe substance use disorders, and we've already discussed the systemic limitations with working here with Quadrant 4. Now, if we could get inpatient to be co-occurring capable even, we would be eons ahead in getting Quadrant 4 services to our individuals. Then we want to determine the intensity of needs. Intensity of needs is actually a terminology that has been used by Medicaid to replace what was otherwise called level of care. And so intensity of need is something that's very specific, and an intensity of needs determination is completed by either using the ACM or the locus. They are both covering a lot of ground, and both are applicable to individuals with co-occurring disorders. Typically, the locus is used in mental health settings because when you look at the care grid, so you look at the continuum of services that are under various levels of care under the locus, they're geared more towards the mental health system. When you look at the levels of care that are available under the ACM, they are more geared towards the substance abuse treatment side of the house. But both are applicable for individuals with co-occurring disorders. So the ACM Dimension 1 looks at acute intoxication and or withdrawal potential. Biomedical conditions and complications is 2. 3 is emotional, behavioral, cognitive conditions and complications. 4, readiness to change. It's actually its own dimension. 5, relapse, continued use problem potential. And 6, recovery environment. Recovery environment looks very much like what you would find in Dimension 4 on the locus. Level of stress and level of support. Locus Dimension 1 is risk of harm. 3 is medical addictive comorbidity, and these map on to both the ACM Dimension 1 and 2. Risk of harm, again, maps onto 3, as does psychiatric comorbidity. Readiness to change looks very much like engagement on the locus. Treatment history and recovery history has a lot of the same elements as relapse, continued use, or continued problem potential. So let's go through these. Common elements of the ACM and the locus. They're both integrated biopsychosocial profiles. They take into account biological, social, psychological, the continuum. And what it does is it helps give us an idea of what the intensity of need is, what the severity of the intensity of need is across all 6 of those dimensions. And when the assessment is really completed well, you have such a robust amount of knowledge about this individual without even being diagnostically driven. These are not diagnostically driven. These are based on presentation and history. There are 6 interactive dimensions of the assessment, so when you do a locus or an ACM, you're continuously going through each of the 6 dimensions and making sure that you have the information that is interconnected between them. They address psychiatric, medical, and addiction variables, co-occurring disorders, and there is a big emphasis on risk, history, engagement, and support. All of those social factors that we've been talking about that really can negatively impact or positively influence someone's ability to engage in treatment. So these dimensional assessments provide a structure to assess both historical factors as well as current circumstances that can impact treatment effectiveness. They allow for ongoing assessment to determine if there is a goodness of fit between the client's intensity of needs and the level of services provided. I'm going to reiterate this because this is one of those pieces of the ongoing assessment. So how do we know that treatment is working? So what does get better look like? So signs and symptoms. So reduction in symptoms could definitely be one element of getting better, right? But we also know that we have an individual that is a human being that lives in the real world and has all of these environmental contexts around them that also can work to either sustain, maintain, or dysregulate an individual, or can add to the benefit and help them actually get better and maintain that wellness. So looking at them within the context, that's one of the reasons why our service delivery system says psychiatric caseworkers, service coordinators are such an essential part, because we realize that the medication or the clinical treatment can only get us so far. We also need to be able to affect the context in which people are living when the recovery environment is poor, when the level of stress in their recovery environment is high, and when they lack a lot of social support. We know that those are huge risk factors that can serve to dysregulate an individual pretty quickly. So as wonderful as we are in getting them ready to go and get discharged, one of the rates of recidivism risks to be very high is when you put somebody back into the environment that we already know was full of environmental and contextual factors that led to their decompensation. So what we use in, at least in the substance abuse treatment field, we use the ASAM not only for initial assessment, but for ongoing assessment, because that's what gives us an indication of, is the intensity of needs that this person presents with, are they being met at this level of care? Or could they benefit from a lower level of care? Do they no longer have that intensity of need so that we can move them to a lower level of care? And what is the evidence for or against that? Additionally, is this level of care working for them, or do their intensity of needs, have they changed? Have we now uncovered that while they've been on the inpatient unit, they do in fact have a co-occurring substance use disorder that will require a different level of care within the milieu? Well, that would be important. Or someone is there for a specific reason and then you begin to uncover that there is some suicidal ideation. Even though you are at a very high level of care, does that also mean that they get even more intense services within the milieu? We also use it to determine, are people ready to be discharged from services? So have we been able to demonstrate that we've had some movement, we've been able to decrease or affect some change on any of these various dimensions, which then lower their intensity of need? So it informs medical necessity by looking at type, duration, intensity, setting, and clinical appropriateness of the placement and treatment. So it's all connected. We use the locus assessment to really help define the severity ratings on each of these dimensions. And based on the severity of the dimensions, it helps inform what type of treatment they need and what placement they need. So characteristics of level of care. In the ASAM, they're delineated by setting, support systems, co-occurring enhanced programs, staff, therapies, assessment and treatment plan review, documentation, and admission criteria. Unfortunately, the locus has not evolved to be nearly as comprehensive as the ASAM has. ASAM was just updated in 2013. In rural clinics, we are requiring that all of our clinical staff are trained in the ASAM specifically, so that when we do have an individual with a co-occurring disorder, we can really take that information and make placement recommendations based on their intensity of need with their substance use disorder in the context of a co-occurring disorder. The locus simply looks at care environment, clinical services, supportive services, crisis resolution, and preventative services. So they also delineate levels of care and service based on the intensity of need. Both of them do this. They require a synthesis to make placement recommendations, and they result in placement recommendations. So you have to gather all of the information, put it all together, and then use that to make your placement recommendations. So this is the way that under Chapter 400 it is identified or defined, the intensity of needs determination. So a standardized mechanism to determine the intensity of services needed based upon the severity of the recipient's condition. The intensity of needs determination is to be utilized in conjunction with the clinical judgment of the qualified mental health professional and or a qualified mental health assistant. This assessment was previously known as the level of care assessment. Currently, DHCFAP, which is basically our state Medicaid office, recognizes the level of care utilization system as the locus, or the CASI for children and adolescents. Even our SAPTA-funded providers that are now providing care under Medicaid, under provider type 17, must use the locus in their PARs. That's how they determine the level of care placement. And as I mentioned before, the global assessment of functioning, the GAF, and the intensity of needs determinations needs to correlate. So if you're saying that somebody needs a medically monitored residential program, and you say that they have a GAF of 70, there's a disconnect. Similar, you want to make sure that someone that has a low GAF, you're not saying needs a level of care placement in a low intensity outpatient service. What this ends up doing, by the way, when you really start looking at all of the various levels of care within the recommendations for what a locus score actually equates to, you'll notice that when you look at our systems of care, there are considerable gaps in levels of service. So where we may not have a lower level of service available for someone, sometimes we end up sticking them in a higher level of care because we don't have anything else. Sometimes people get stuck at a higher level of care because we don't have anything at a lower level of care to really adequately treat them. So that's another piece that we'll get into when I start talking about medical necessity, because the disconnect between the availability of services and the level of care placement can really get clinicians in a tough spot when they cannot demonstrate that the level of care that is so high meets medical necessity. And yet, hospitalization is very costly, both in time and resources, and is probably not the most adequate setting to meet all of the needs of the individual. Particularly if the level of care is too high, sometimes that can have some negative implications for an individual actually achieving recovery. So that continuum of care really is a very, very important piece in all of this, because we need to make sure that we are matching an individual's intensity of need with the appropriate level of care. There are 50 different ways that anyone can reach a high severity on any one of those dimensions. How do you know what you're affecting change on? If it stays 4 all of the time, have we actually targeted interventions to bring the severity down on that one dimension? It's hard to tell because we don't know what actually caused them to be at such an elevated score to begin with. So it's, in my opinion, it's completely underutilized in our system. And it's a shame because it's so rich with information that we would actually be able to target our interventions more meaningfully if we were all using it in the way that it was intended to be used, and targeting our interventions to bring down severity ratings where we could affect change. So this is out of David Mee Lee's work. He's in the Change Company and down in Carson City. But this is a way that he has kind of developed a scaffolding process to identify and target and focus priorities of treatment. So he starts off with the question that we've actually brought up several times now in the training, which is, what does the client want and why now? Are there immediate needs due to imminent risk on any dimension? Obviously, if there are, it trumps pretty much everything else. We want to conduct a multidimensional assessment. That's the locus or the ASAM. We want to look at the multi-axial diagnoses. Looking at the multidimensional severity, which assessment dimensions are most important to determine as treatment priorities. Choose a specific focus and target for each priority dimension. Consider what specific services are needed for each dimension. What is the dose or intensity of these services that is needed for each dimension? How often do we actually think of psychological services, counseling services in terms of dosage? We think of it in medication terms, but really you're looking at the frequency and the intensity of those services, and some psychological services or counseling services are much more intense and really need to be delivered in a dosage that's actually going to be effective. So meeting with a therapist once every 45 days when you actually really require an intensive outpatient program is probably not going to fit the bill. So is it treatment? Yes, but that would be like, treating an aneurysm with an aspirin. So we have to look at dosage and see what is the most, what is the highest level of care that this individual needs to affect some change. So you're right, because treatment matching takes into account not just what the intensity of the needs are that the individual has that's going to result in our treatment recommendations, and that meets medical necessity, right? That's where our clinician's hat comes on, is what is this individual most likely going to need in order to get better. The other side of that is patient choice. And so unless there's imminent risk of danger to self or others, where that's an automatic legal, there's a lot of latitude that we have when we're working with our clients to figure out, are they ready, willing, and able to engage in other services? And if so, what are those services? There are lots of barriers to treatment, but that also comes with informed consent. My recommendation would be this level of care. If you are not ready, willing, or able to, go into this level of care, then let's talk about what you are willing to do. Is it that you're willing to meet with a peer support specialist once a week? Are you looking for housing or case management to really take care of some of those social needs first? Are we looking at engagement or persuasion, or is this person really ready for treatment? And then having those discussions with them and then matching our treatment to the way that those two things coincide with one another.
And what level of liability do we have in that? We know the level of treatment that they need to be in, and we're ready to connect them, and we're gonna get this going and stuff, but it's not the level of where I can just do a legal 2000, which I'm ready to do.
I think if you documented that this was the level you recommended, this was the level that the client,
And they have been informed of all of the risks and benefits for not going to the level of care that you've recommended. And by the way, you've identified that they're in contemplation for their substance use disorder, so you're going to work with them with motivational interviewing to enhance motivation, while at the same time they're in the action stage for their bipolar disorder, and you're hooking up with medication management through psychiatry to meet them where they're at, and maybe you're also going to put them in a DBT group for emotion regulation, because that seems to be a big problem for them. Easier said than done, absolutely. I get that.
In a rural setting, it's an interesting discussion every time you're at the table, because there's not that many resources.
There aren't that many resources, and so then it's looking at the resources that you have internally, and are we utilizing everything to the best? Do we have enough of a continuum of care where we can meet most of the, because sometimes we come from the frame of reference that everybody needs therapy. Well, not everybody wants therapy or needs therapy, so is there another use of that level of qualified individuals to provide a different level of care? Maybe there's a subset of individuals that really could benefit from IOP. And so can we structure our clinics so that we can use IOP in conjunction with lower level outpatient services? So then where can these services be provided in the least intensive but safest level of care? And safety is a huge consideration when you're looking at medical necessity. And then what is the progress of the treatment plan and placement decisions, and what are the outcome measures? What are we really trying to affect change on, and how will we know when we got there? Common elements of the ACM and locus, they also preserve clinical judgment. So there's two pieces to medical necessity. There's medical necessity, and then there's clinical appropriateness. And those are different hurdles that you need to kind of jump through in order to establish what is the best match for this client and their needs. They're also considered broad, flexible, and adaptable. So they're not very rigid. It's not that, if you get a score of this, then it automatically puts you here. You also want to look at, clinically, is this the most appropriate fit for this individual? And it encourages patient-centered care planning and facilitates decisions of medical necessity. So ethical considerations. It is an ethical consideration when you're looking at the participant's assessment, the problems or priorities, the plan, and the progress. So it's this consistent circle of what is going on with the patient, what are their problems, what are their priorities, How are we addressing them in the plan, and what has been the progress towards the plan? So that this is the feedback loop of that constant assessment process. It's not just assess, we need to also then prioritize based on our assessment. Does this shift our problems or our priorities around? Have new problems arisen that otherwise we hadn't known about that are gonna change our priorities in our plan? And then are we monitoring progress, and if so, how? And then does that inform when we're gonna assess the patient next? And really, I think the underlying process here is informed consent as well, because you have to be evaluating with the patient the risks and the benefits of all of the treatments that are provided and the risk and benefit of choosing no treatment. Because there are risks and sometimes there are benefits to no treatment.
People can choose to go on having a lousy life.
They can choose, you're right, they can choose to do any number of different things. And so really, if we want to be the most effective at helping an individual implement a plan, a treatment plan to get them to where it is that they say they want to go, we need to be able to partner with them. Which definitely gets us out of the medical model of here's the problem as I see it and this is what I'm prescribing to you, take it or leave it. But it's really much more of a collaborative partnership. Okay, so medical necessity. Medicaid 103.1 defines medical necessity as a healthcare service or product that is provided for under the Medicaid state plan and is necessary and consistent with generally accepted professional standards. 2, diagnose, treat, or prevent illness or disease, regain functional capacity, or reduce or ameliorate the effects of illness, injury, or disability. It's broad because this goes to everything from a hangnail to an individual presenting with substance-induced psychosis to someone presenting in full cardiac arrest. So the terminology does not change. Medical necessity is medical necessity. You also have to jump through a couple of other hoops here in determining the type, frequency, extent, and duration of treatment. It has to be scientifically based with guidelines of national medical or healthcare coverage organizations or governmental agencies. So basically, is this the standard of care? The level of service can be safely and effectively furnished and for which no equally effective or more conservative or less costly treatment is available. Services are delivered in a setting that is clinically appropriate to the specific physical and mental behavioral health care needs of the recipient. And services are provided for medical or mental behavioral reasons rather than for the convenience of the recipient's caregiver, or the healthcare provider. So are we doing it just out of our own convenience, that really this is all that we've got and so that's what we're gonna do? Or are we actually looking at how we can make the connection? Because especially in our rural communities, we don't have a full array of services, nor do we have the resources to be able to provide them. So when you're looking at medical necessity and you see that medically, someone needs a higher level of care but doesn't necessarily meet the requirements of hospitalization, but you only provide a level 2 outpatient service, what other services can you then provide to augment what it is that you have available so that you may not be able to provide it to the extent that they need it, but you're providing something? Because we also don't want to be neglectful. So medical necessity shall take into account the ability of the service to allow recipients to remain in a community-based setting when such a setting is safe and there is no less costly, more conservative, or more effective setting. This, I think, speaks a bit to what we were just talking about for individuals who maybe are institutionalized for a significant period of time, but could potentially be managed in the community. So how do we get them there? And I apologize for reading some of these slides, but this is the language, and I want to make sure that you have exposure to exactly the way that it is written, because as they say, this is the letter of the law. Okay, so after all of that, we want to determine diagnosis. So the client history is important. We want to document prior diagnoses if they have existed. What are they? Link mental health symptoms to a specific period of time, and remember, above all else, when it comes to diagnoses, all diagnoses should be considered presumptive. We're doing the best with what we've got, with what's in front of us. So, we have a little bit of DSM-5 related to substance use disorders. I'm gonna kind of breeze through this because we did touch on some of it yesterday. In case you don't know the history, the first one was published in 1952, the third in 1980. At that point, they had habitual excessive drinking added. DSM-4 was 94, DSM-5 just came out in May of last year. So the idea here for doesn't label people, they're working more towards a person-centered language. So a person with an alcohol use disorder versus an alcoholic. I am not my disorder, I am a person with a disorder or a disease. And substance use disorders is the largest single section in the entire DSM. So some basic changes with the DSM-5, moving from DSM-4, substance-related or substance use disorders versus substance use and addictive disorders. So we have some of the substance categories have changed. The multi-axial workup is gone, and so is the GAF. I'm sure you're aware of that. How many of you have actually had training on the DSM-5? So some of you, okay. Legal has been taken out of the criteria for substance use disorders, and craving has been added. Abuse and dependence are no longer specifiers. Now we're looking at a continuum of severity from mild to moderate to severe. And gambling was also added. So here are all of the various disorders. I'm not going to read through all of these, but some of them have had changes and some of them have not had changes. You're going to have all of these slides, so if you'd like to reference them in the future, you can. More diagnoses, there's lots of them. So when you used to see polysubstance use disorder, it's not there anymore. And actually, if you read through the criteria for polysubstance use disorder, it's actually very specific, and it was used like an NOS diagnosis as kind of the garbage can, like, well, they're on all sorts of stuff, and we can't figure out really if it's abuse or dependence, so we're just gonna give them polysubstance dependence. Not anymore. So we're actually gonna have to do a little bit more digging to really nail down what are the substances and what is the level of severity for each of those substances. Okay. So this is what substance abuse used to look like. One or more of these in the same 12-month period for the same drug. So the issue here that they have taken out is the recurrent substance-related legal problems. Why? Not everybody who has a substance dependence issue has legal problems, and legal problems actually is not necessarily contingent upon someone having a disorder or not. So substance dependence, they had to have 3 or more of these during the same 12-month period for the same drug. So tolerance, withdrawal, taking in larger amounts or over a longer period than was intended. Think about the questions on the MAST and the DAST that you went over earlier and see if any of these map on to some of those questions to see what they were getting at. A persistent desire or unsuccessful efforts to cut down or control substance use. A great deal of time spent in activities to obtain, to use, to recover from a substance. Important social, occupational, recreational activities are given up or reduced. And the use is continued despite knowledge of having a persistent or recurrent physical or psychological problem caused or exacerbated by the substance. So you have someone that you know has a heart condition and is continuing to use an amphetamine or some type of stimulant, and they know that it's bad for them, but they continue to use it anyways. Okay, so DSM-5 criteria now. Criterions 1 through 4 really are classified under impulse control. So the idea is that the drug is taken in larger amounts or over a longer period of time than was intended. So when you have an individual coming in and say, you know, I was going out every night with my friends for a beer after work, and before I knew it, I was blacked out in a parking lot with my car running. Not sure how I got there. And this has happened several times over the course of this last month. And every time I go out and I say I'm only gonna have one beer, but then I end up in similar situations. So using more than they had planned to or intended. Important also specifier for individuals who say that they are recreational users or believe that they're recreational users. Have they lost some sense of control over how much they're actually using? Is there a persistent desire or unsuccessful efforts to cut down or control the use of the drug? So I've only bought one 1 ounce of whatever the substance is to try and cut back. But then I find that I'm out 4 hours later searching for more. So they're really trying to modulate their own use, but it's not successful. A great deal of time is spent in activities necessary to obtain the drug, use the drug, or recover from its effects. So you're considering how much time does the client spend finding the drug. You would be amazed at how many individuals with a true severe substance use disorder are spending the vast majority of their time seeking the drug, using the drug, or recovering from the effects of the drug. And sometimes all while working. Or,
It's like a full-time job.
yeah, or otherwise functioning fairly well in life, but they have worked out their schedule so they know that they can use 4 hours before they get on the job so that they're, right where they need to be for optimal functioning. Because remember, not everybody uses to get high. Some people use because they feel that it enhances their ability to perform at high levels. You can think about people who use Adderall. They don't have ADHD, but they like that psychostimulant so that they can have increased concentration, memory, and perform at high levels. We see it all the time with students. It has a very high abuse potential because it can be very performance enhancing for them. They also have a craving or a strong desire or urge to use the drug. Craving before was not part of it, but we know that craving for some people can really put them into overdrive, where they are preoccupied with the use, the need to use. And this isn't just a physiological craving, this is also a psychological craving. So they may not actively be using every single day, but their cravings daily are a 10. And when you ask them to actually describe what does that craving feel like for you, they can go into pretty great detail as to what it is that they're really experiencing and how overwhelming or distracting it can be to keep them from really being able to function. So criterion 5 through 7, social impairment, recurrent drug use resulting in the failure to fulfill major role obligations at work, school, or home. So an example of this has drug use affected the client's obligations at home, such as paying bills, providing for children, taking care of sick family members. Continued use despite having persistent or recurrent social or interpersonal problems caused or exacerbated by the effects of the drug. And this can get to a number of different things, not just having disrupted relationships, but where relationships previously had been very functional and very satisfying for them are no longer because either a friend, a parent, a partner is really having conflict with the individual in their use. And important social, occupational, or recreational activities are given up or reduced because of the drug. This could be because they're so busy looking for, using, and recovering from the drug that there's only so many hours in the day and they're really limited in their ability to engage in meaningful activity, or they no longer have the physical drive or the ability to engage in these. Recurrent use in situations in which it is physically hazardous. So people are driving while intoxicated. Maybe they're going and picking their kids up from school while they're intoxicated or recovering from use. So taking a look at, are they engaging in risky activities while using? Even if they're working and they're driving heavy machinery, which is not unheard of. Drug use is continued despite knowledge of having a persistent or recurrent physical or psychological problem that is likely to be caused by or exacerbated by the drug. This really hasn't changed. But questions like, what mental health problems does the client experience that are related to the drug use? So the chances of you actually convincing an individual that has a methamphetamine psychotic disorder that their delusions are not real and their psychosis is the result of their drug use, you may not get a lot of leverage being able to convince them of that. But if they know that every time they drink, they become suicidal and depressed, and they end up in the hospital, and they're able to make those correlations for themselves, and they continue to drink, it would fit this criteria. Tolerance. Does it take more of the substance to reach the desired effect than some time ago? I was working with a woman that had a severe opiate dependence, and the amount of medications that she was consuming on any given day, if she hadn't built up the tolerance to it physiologically, I mean, her kidneys were shutting down, her body was in dire straits. The physician said that if they had given that same dose that she had taken in one day to a horse, it would have killed it easily. So the amount that our bodies can begin to tolerate over prolonged and consistent use is amazing. And then withdrawal. So what happens to you the next morning after drinking or using? Oftentimes, people don't associate withdrawal with drinking because their tolerance is so high that they don't have a hangover, even though they drank a fifth the day before. But when they wake up, they're also not noticing that they're shaky, and they're going to have that first drink first thing in the morning. They're considering it kind of continued use and not necessarily paying attention to the withdrawal symptoms. But paying attention to how you feel and the contrast between, do you feel better in the morning or worse, can help clear that up. Okay, so again, during the same 12-month period, no diagnosis is if only one of those 12 criteria are met. Mild if 2 to 3 are met, moderate if 4 or 5 are met, and severe if 6 or more of those criteria are met. And then we have course specifiers. So we no longer have physiological dependence with or without. Early full remission, early partial remission, sustained full remission, sustained partial remission was always very confusing for people and not used very accurately. So oftentimes they were left off, and yet it is probably one of the most important specifiers there could be, because what it does is it substantiates how long has this individual not used, and has it been consistent, or have there been periods of relapse. So now they have in early remission, so the criteria is not met for 3 months, but less than 12 months, and in sustained remission is not met for 12 months, except for craving. Craving is still allowed even after 12 months. Why? It's for some people, they could have cravings for 20 years, for 30 years, for even longer than that. It is a normal part of the process of recovery. We can't expect it to go away before we actually say that someone has recovered. Agonist therapy is now considered maintenance therapy. And of course, we also need to note if they've been in a controlled environment or not. Makes a huge difference if someone's had 30 days clean and sober in their environment versus in a controlled environment. And then we want to determine disability and functional impairments. So this is where I had that Anderson Cooper video that I showed you yesterday. We want to determine current and baseline functional impairments. And this helps to delineate the level of care requirements. So how much assistance is needed for an individual to meet their basic needs and access treatment? So can the client live independently? Can they support themselves financially? Are they engaged with social supports? And do they understand and make use of services at a lower level? Here also, we're talking about level of care requirements, because if someone has a severe functional impairment, otherwise known as gravely disabled, there are all sorts of other terms that people use to describe that. But if they are, if their symptoms are so severe or their functional status is so impaired, because as a direct result of a psychiatric illness, sometimes they need a higher level of care. Okay, so level of care characteristics. I'm not going to read this whole entire thing to you. I just wanted to put it in here to show you that when I went through the locus, the different characteristics for care settings, those are here. So the client's living situation, their recovery history, supervision and contact needed. So how much supervision and contact is really needed for this individual? Is it daily? Is it weekly? Is it 24-hour supervision? Is it 24-hour monitoring and supervision? Other, so is there some community or home-based services? Can it be done in a clinic, in the community? Does it have to be in a facility? Care environment, so can they come and go as they please, or is it a locked facility? Clinical services, what types of clinical services are available? It even delineates the availability of nursing and medication or medical care. Supportive services, so it looks at case management and what is the frequency of contact and intensity of contact with case managers. And crisis stabilization and prevention. So if you were to require level 2 low intensity community-based services, which is basically what we provide in all of our outpatient clinics. The individual should be independent, living with minimal support. The client, their needs are generally for ongoing support for recovery. They don't require intensive management. It can be done in the community. They can access can be monitored, but egress cannot be controlled. Basically, you can have a security guard standing at the front of your door of your clinic, but you can't control when people come in or out. Let's see. So clinical services, up to 3 hours a week, but not less than 1 hour every 2 weeks. Medical management is about 1 time every 8 weeks. Medication use can be managed, usually by the individual. Individual, group, or family therapies are available. Case management is usually not required. They may need help accessing certain services. They may need assistance with coordination with support services. And then basic means that basically, regardless of the level of care, there should be at least 24-hour availability for crisis evaluation, brief intervention, and respite. All of these other basic services should be available to them. Medically managed residential services is typically where you see our inpatient psychiatric services classified. Okay, any questions or comments thus far? So identify strengths and supports. Strength-based, right? Person-centered, strength-based. Really want to know, what does this person do? What do they do well? And how can we build on those strengths? So what are their talents and interests, areas of vocational skill, social skill, capacity for creativity, areas connected with high levels of motivation. So what really motivates this person? They may not be in treatment for themselves, but they may be in treatment to get their kids back from child welfare. They may be in treatment because they're court ordered. They may be in treatment because they're at risk of losing their job. So we need to know, what is their motivation? Why are they here? Previous treatment episodes, what worked? So have you ever been in treatment? Yes, 50 different times. What worked? Nothing. Okay, what did you not like about it? And they can tell you every reason that the treatment didn't work. And then they can tell you the characteristics of the people that they worked with that maybe weren't so helpful. So we can work with that, whatever the knowledge is that they want to share with you, to help identify what could work then. How can we remove some of those barriers? Current successes, treatment plans need to reinforce strengths. Where are the opportunities for enhanced quality of life? The enhanced quality of life really is at the essence of recovery. It's not necessarily symptom reduction, unless that is a priority that the individual says they want. I've met many individuals who say that they would be perfectly happy to have some of those voices remain if they could stop drooling on themselves and could actually pick their feet up so that they could ambulate properly. So there's a cost benefit there, but it's a real one. And the ability for someone to have that motivation to continue to take a medication that they don't feel is allowing them to live their life to the fullest, their adherence or compliance tends to plummet after they're no longer monitored or contingencies are put on them to comply. And being person-centered versus program-centered. Program-centered is, this is what we got, take it or leave it. Person-centered is, this is what we have. It may not be the best for you, but do you see if any of this would work for you? And if not, what other things do you think would be helpful? Not to say that you have to be able to provide it, but at least walking them through, talking them through that conversation to really figure out what are they looking for. Because if they're looking for voc rehab and you're putting them in group therapy 3 times a week, we're gonna have a disconnect. So if they just need a referral to voc rehab, that's a lot easier than putting them into group therapy 3 times a week and then having to chase them after no call, no show, no call, no show, no call, no show, and then sending a welfare check out because we don't know what happened to them. So really trying to figure out, are we gearing our treatment plans towards the individual and what their desires are, or is it only because it's what we offer? Identify cultural and linguistic needs and supports. So we want to be culturally sensitive about our planning, and culturally sensitive does not necessarily mean that it's only culture for what's visible. So many people have strong cultural ties to cultural dimensions that are not necessarily obvious just by looking at them. So this takes some actual questioning to figure out what is most salient and significant for the individual. Because what may appear to be important because it's overt may not necessarily be important to them. So really getting an idea of what is going to be the most important and salient for this individual to address in treatment. Some individuals may not fit into the treatment culture. Our clinics are open from 8 to 5. Someone works full-time and still wants to engage in treatment. They may not necessarily fit into our treatment culture. There may be cultural and linguistic barriers and issues with learning styles and abilities, particularly if there are some type of cognitive issues. And some people really are just not meant to sit and be part of a psychoeducational didactic 90-minute group therapy. They may actually need something a little bit more kinesthetic, and are we going to be able to make accommodations for that? So now that everybody's half asleep, I'm going to make you talk to each other again. All right, so in small groups, get together and consider your professional experiences to date. We have lots of wonderful experience in this room. What is one experience that has led, one experience you have had where a person's cultural needs challenged your competencies? And how do you currently assess for cultural issues that need to be addressed for interventions to be effective? So I'm going to add to this one just a little bit. So what is one experience that you've had, and what did you do about it? And then how do you currently assess for cultural issues that need to be addressed for interventions to be effective? So you understood the cultural context as she explained it to you, and still helped kind of give her a perspective of what the expectation is for treatment while being sensitive to her issues, and even brought in family.
Exactly. Actually,
So you, instead of
Say
you have to do it and kind of forcing more resistance against what he was seeing as a cultural bias on your behalf, you recognize some choice. Yeah, great. What do we typically do when we're faced with challenges, especially around cultural competency, to resolve them or mitigate the issues as much as possible? What do you typically find yourself doing? Seek more information.
Educating yourself if it's something you're not necessarily know about.
And you can do that a number of different ways. You can seek information, online, read books. You can ask the client. Yeah, find someone that's of a similar culture or the same culture and use them as sort of your expert consultant to help you better understand the culture at hand. So seeking that expert informant, the individual from the culture, to give you sort of what is the normal or normative experience of an individual, or what are the normative kind of beliefs or customs within a certain culture. Great. Yeah, a lot of people will go and seek additional information, and then it's the challenge of how do you translate that additional information to inform how you approach an individual. So usually having conversations, we were actually discussing a little bit around putting it out there too, because it may not be an issue for them, or it may be a huge issue that's actually a barrier within the therapeutic relationship. So getting an idea from their perspective, is it really a big deal or is it not a big deal? And what parts of their own cultural experience beyond just ethnicity are kind of covert that you can't necessarily see or detect, that may also be barriers if they're not allowed to be brought up and discussed openly in a relationship. Good. So how do you currently assess for cultural issues that need to be addressed? Very good. So on the nursing assessment, there are actually questions that you ask patients as they're on the inpatient unit that can help you maybe at least better understand. Okay, great.
Some of the things that
So there are sometimes conflicts between helping someone feel comfortable and feel like their cultural needs are being addressed in a way that's meaningful to them, and maybe in direct conflict. And I imagine here in Las Vegas, because it's such a crossroads for so many different cultures, that you may end up with people on the unit that there really is limited translation for, limited communication to really understand what their needs are.
Yeah, there is the phone line that for basically getting, 24/7 being able to get an interpreter, but beyond that.
sometimes I can't even get patients to come to the phone
Yeah.
though, like they don't even so it's,
Maybe a little paranoid
Yeah.
about you and the phone, so.
I don't know what I'm trying to do to them probably.
Right.
So then you're just stuck.
That's a whole other level of challenge. Right. So there are lots of different things that can impact someone's willingness to engage with treatment, and cultural relevance is just one of those. And then we've already spoken pretty extensively about additional social factors that can really be barriers to treatment and need to be identified so that they can be addressed. And so those are physical health, housing, vocational, educational, social, spiritual, cognitive, all of these multiple factors all coming into play in one way or another. Now, they may not be relevant, all factors may not be relevant for all people, but it is important to keep in mind that they may be relevant, and it may be the one thing that's really keeping someone from being able to access care. Childcare, I know, for a lot of women is a real big issue because they can't afford babysitting. So you can't just say, well, just get somebody to watch your kid, and then you can come to treatment. And not every parent is willing to do that either. And so how do we work with them to engage them in treatment while helping to identify some of the issues that could prevent them from being in treatment? So you can use tools such as the ASI, which is the Addiction Severity Index, to help identify other problem areas that may negatively impact treatment outcomes. Be aware of contingencies and maintaining factors for treatment adherence or lack thereof, both overt and covert, regarding treatment for both disorders. Basically what that means is if you are providing treatment and it's adequate and meets the individual's intensity of needs and nothing is happening or it stays stagnant, it's a good opportunity to take a step back and reevaluate, because there may be a piece that's missing. And we all know, especially within family systems, and that family systems approach can translate to many, many different systems, that oftentimes someone could be working really hard in treatment, but there are so many other maintaining factors in their environment that really deep, meaningful change can be very difficult to obtain. So taking a look at both overt, which is obvious, and sort of those more undercover factors that could maintain or interrupt treatment outcomes. So determining readiness for change. How many of you, just by show of hands, are familiar with the stages of change? Okay, great. So why do we determine readiness for change? Why would readiness for change be an important component to the assessment process?
Well, it determines how you intervene.
It determines your intervention. It can help inform what stage of treatment someone is in. So are they ready for active treatment, or do we really need to work more on the persuasion piece, the engagement piece? Where really are they in the continuum? So we know by this point in our assessment, we have a pretty good idea of what their intensity of needs are and what their treatment needs are, and which quadrant of care or locus of responsibility they would probably best be treated. But if they're not ready for the change and we send off a referral, they likely are not going to engage. So what we need to do is also determine readiness for change, because we can see somebody needs detox and they are continuing to use, they need a residential level of care, they need admission to a psychiatric hospital for stabilization, but don't necessarily meet criteria for a legal 2000. How do we get them there? Because people have choice. And so we can use things like motivational interviewing, motivational enhancement therapies to help gain some ground and move them towards change. But it's really about listening for what type of change talk do they have? Do they see it as a problem or not? And how big of a problem? And then do they feel ready, willing, and able to implement that change? Do they feel like they have the capacity to make that change? And how important is that change to them? So we want to be pulling in all of these different data points to help inform their readiness for change. And treatment plans really do the patient no good when they're unattainable, when they're unrealistic or they do not fit the individual and their needs. Better to have a treatment plan that is achieved in 3 days that has to be redone than to have a treatment plan that will never be achieved, or at least in a reasonable amount of time. So it's much better to look at the treatment plan for the milieu or the level of care that they're at. So is this attainable and realistic and measurable and observable within the milieu that they're in, so that we can really determine, is this treatment level effective? Have we attained our goals? But if you always are writing them for 6 months out, how are you ever going to really attain those goals within a 26-day period of time? Especially when there are elements to it that really aren't able to be provided within the milieu. So readiness to change. Evidence-based practice says that we need to match our treatment interventions to the stage of change for both disorders. So this is a little bit of how this works. So you have an individual that comes in and you've already diagnosed them with a mental health disorder. So throw out a mental health disorder. Depression. Okay, so here they have depression. And what's the scenario with depression? They have a history of depression? Isolation. So they isolate. Pardon me? Lack of interest.
Lack of sleep. Or too much sleep, right?
Too much sleep. Okay. So their sleep is disrupted, right? Too much, too little. Okay. Maybe they're ruminating.
Crying jacks.
Crying?
Hopelessness, helplessness.
Crying. Okay, so we've got the whole enchilada here when it comes to depression.
And maybe with psychotic features and may not.
Okay, so sure, we'll complicate it. Okay, so maybe they have a history of depression. This is their third depressive episode. We're just making this up as we go. Third depressive episode. They've been engaged in treatment before. Once they did talk therapy, so their history, they did therapy, CBT, and they say it worked for a while. Okay? It worked for a while. We did it. It was good. My therapist, he was cool. We worked it out, and then I didn't need treatment anymore. And once it was situational. Let's see. This is a male, female. What do you want? Male or female?
Female, let's make it complicated. Postpartum depression.
Okay. Well, how about once it was situational, but it was the baby blues?
Okay. Then the third time was empty nest. No.
Okay, sure. So she's 65. Okay, so she's 65. She's coming into you, depression with psychotic features. She's got all of this going on. She went to therapy once, CBT, it worked for a while. Once it was situational, it was baby blues, but it kind of took care of itself. And one time she was hospitalized. She was hospitalized for depression. Okay. And suicidal ideation. They put her on medication, which she discontinued in 2 months. She didn't like the side effects. And I'm losing my earring. Okay, so are we in an inpatient or an outpatient setting right now? Where are we? Inpatient? Sure, let's do inpatient. I'm gonna just keep this out. Okay, so we're inpatient. Okay, so she shows up, and this is what we know about her. Okay? What's her drug of choice?
Let's do benzos.
All right. Okay. Sure, especially if she tends towards depression. Yeah, let's go there. This will be consistent. Okay, so so she's taking benzos. Every once in a while, she'll also drink, because of course, where there's one, there's usually the other. Okay, and then maybe a little cannabis. We'll start with this. This is a good laundry list, okay? We don't have to conquer the world in this one demonstration. We'll be okay. Okay, so benzos, occasional alcohol, occasional cannabis, particularly when her benzos run out and she needs to find a replacement. Okay, so has she ever been in treatment before for any of these things?
Well, she was in talk therapy before for mental health.
But has she ever been in substance abuse treatment? No. Okay. No treatment. Let's say her benzos are actually prescribed by her primary care physician for anxiety. My nerves. So PCP, it's for her nerves. For the last 15 years. Not a problem, right? It's not a problem. Okay. So she's never had treatment. Let's see, what else? She is saying, you know, it's not a problem. The benzos actually work. I haven't been depressed in a really long time. This onset is really very sudden. I'm not really sure where it came from. It just kind of came out of the blue, right? Like, hit me like a Mack truck. Here I was functioning, working, doing just fine. And, you know, alcohol, occasional, not really admitting to much. Cannabis, okay, let's do that. One DUI.
Yeah. A long time ago. Long time ago, and it was just fine. In a different state.
Okay.
She's out with friends.
So she's been taking benzos for 15 years. What was her onset of alcohol use? How old do you think she was when she started drinking? Teenager, 15? Okay, 15. She considers herself a social drinker.
She lowered the level in her parents' bottles when they weren't home.
Okay, so she would sneak it. She drank to intoxication by 16.
Mom and dad were both, dad was an alcoholic.
Let's see, mom and dad both, okay.
No, dad was an alcoholic. Mom just kind of shut away, went to a room and read the Bible.
Because she was depressed. So dad had alcohol issues and mom was depressed. Okay. So drank to intoxication for her first time at 16 and maybe did some serious binge drinking through junior college.
Which friends didn't drink alone?
Okay. Okay. Stopped drinking during her pregnancy. Yeah. So when she had her first kid, she stopped. It wasn't a problem. No big deal. And actually it wasn't until, you know, a friend's wedding a couple of years later when her kids were a little bit older that she started drinking again. And since then she's just kind of been a social drinker.
They went through a bad time because husband lost his job.
How old was the first one?
This is becoming a really extensive creative writing process.
I was saying, because this is your generic outpatient.
You're right.
You have to throw in fibro, and she's on opiates too.
Don't forget
Right.
borderline personality disorder.
Yes.
Mom, and now
Okay,
it's
so
father.
let's look at the constellation here. Okay, her risk right now, she's on the inpatient unit. She's not currently suicidal, but she has some psychotic features that we think are related to the depression. So she really, over the last 2 weeks, her functioning has just plummeted. It started with depression. She thought she could just wade her way through it because, you know, before it's kind of gone away on its own. And all it's done is gotten worse and worse to the point where she's really very isolated. So she comes in and she says, you know what? When you're talking about stage of change, she says, I know I probably should do something. So I'm ready. I would like to maybe try a medication, but I don't want anything with like really bad side effects. You know, I'm menopausal and I really don't want to gain any more weight than I already have. But really, if you could give me something to sleep, that would be lovely. I would love something to help me sleep. But she's open to exploring medications, okay? Therapy, she says, absolutely. It worked for me before. I think it would be great again, so let's move into therapy.
You need such nice people there.
Absolutely. And, you know, maybe this therapist will be the therapist that I stay with for a really long time because they're just awesome. So her stage of change for her mental health disorder would be what?
I would say action. Well,
She's somewhere between preparation and action, right? Okay, so I mean, and this is all hypothetical, so we can give ourselves some latitude. And let's say she's in action. She actually told somebody that she thinks she needed to be hospitalized because she was having all of these really odd perceptual experiences, and her depression was so bad that she was open to it. She didn't fight it. She said, yes, I'm pretty sure I probably have to go. So she's here. She's ready. We're going to say she's in the action stage. All right.
She's open to medications, but don't touch my benzos.
Okay. She doesn't, not a problem. Been taking them for 15 years.
Why would anybody even think to touch them?
It's not an issue. And actually, when you do your assessment, for alcohol, currently, not lifetime, although it's been an issue, her current alcohol use meets a moderate. We'll give her a moderate severity. Okay. Her cannabis use really doesn't even register. It's so occasional that it's not a problem. So we might give it mild. It may not even be a problem. So we'll give her mild severity. The problem is when she runs out of her benzos, and she tends to run out before the prescription has really expired. So she's maybe overusing on occasion, and when she runs out, that's really when she turns to the cannabis. So she's really just kind of replacing one with the other. And oftentimes it's a cocktail of the cannabis and the alcohol to hold her over from the benzos.
She's already been talked to by her PCP because she has come back twice saying she's lost the prescription.
Okay.
I'm sorry, she lost the pill.
Yes.
I mean, he renewed it early twice, but he said, I'm not doing it for
Okay. So for her benzos, what are we going to rate her severity for her substance use disorder? Severe.
And I know they can pull up on the pharmacy's website to find out how if she's doctor shopping and getting that.
Right. She's actually a pretty straight-laced lady. She's just, really struggling with modulating her own intake of her benzos. But she doesn't see it as a problem. Okay, so where do you put her in a stage of change related to her substance use disorder for her benzos? Because we're not even really going to go with the cannabis and the alcohol right now.
Pre-contemplation.
Pre-contemplation, not a problem. What's the problem? Okay, so we've gotten this far. Now, let's see. So we've engaged her. Let's see. We pulled in her husband. We called him. She signed a release of information, and he confirmed, you know what? She hasn't been able to get out of bed for like 2 months. She lost her job. Things are much worse than what she was reporting to us. And actually, she started talking to herself, which was what had really started to concern him. So he was the one that brought her in. And she was okay with that because it was starting to scare her too. Still not suicidal though, so not really a high level of risk there, but definitely was not caring for herself at all. Had stopped showering, was starting to feel hopeless, was crying all the time, and these perceptual experiences, the psychosis was scaring her. So she's saying, yeah, I think I really need to get some help. Okay, so we screened for and detected co-occurring disorders. We've done the diagnosis for the mental health disorder and the substance use disorder. We have a severity for mental health and substance use disorders. Appropriate care setting. Well, she showed up on the inpatient unit, and she definitely has some psychiatric issues that need to be cared for. She also is coming in with a co-occurring substance use disorder. So we would say that for now, inpatient is really where she belongs because she needs to become psychiatrically stable. We've determined our diagnoses, and we've determined disability and functional impairment. So what kind of gaffe would you give this lady? Hasn't been able to function really for the last few months, hasn't been able to get out of bed, isn't showering.
Depending how psychotic, 25 at the bottom, maybe.
We'll give her kind of that, we'll give her the 35 to 40 range. Okay. And when we look at locus, we're saying functional status, high severity, because especially because it's an acute onset. She's previously been very functional. She's got some co-occurring substance use disorders. Her risk, she's not suicidal or homicidal, but her mood has really plummeted, and she is saying that she does feel hopeless and helpless. So while it's not imminent risk, there's definitely some risk factors involved, especially because she was hospitalized previously for suicidal ideation. Never made suicidal gestures though, just some thoughts. So for her locus, the locus score, especially because of the psychotic features and the functioning, is saying she needs to be on inpatient as well.
Med-wise, you'd want to know, was this something she took many years ago where it was more like the tricyclics, or has she been exposed to the ones that are more SSRIs?
Okay.
What's failed and what were the side effects?
Great. Okay, so let's start talking about therapy, treatment. We know where she's at right now. She's on the inpatient unit. So short term, what are our goals?
Obviously, she's invested in doing talk therapy, so obviously we're going to get her involved.
Okay, do we have talk therapy available on the inpatient unit?
To some level.
Okay, is she going to be able to engage with someone now, or would it be better short term? What are we looking for?
Her to take care of herself.
Okay, so we want her to shower. We want to improve her functional status, right? So improve functioning. So we want her to shower. We want to engage her in some discussion around medications. Some behavioral activation, awesome. And so that could look like groups. Walks, good.
Is she going to be prescribed these benzos while she's in the hospital, or is she going to go into an acute withdrawal?
We don't know. We're not on the substance abuse yet.
Okay.
But let's talk short-term mental health treatment. What are we trying to do? We want to improve her functional capacity. We want her to start taking medication. She's open to that. Maybe we want to talk to her. CBT, she liked it. It worked for her. So if we have the capacity to do CBT on an individual level with her, awesome. If not, groups. And here's our evidence-based practice. We've got CBT. We also may be working with her within the milieu to do some of that behavioral activation. So are we going to put together a plan for her where we're going to be prompting her verbally to take showers every day to see if that's the lowest level of intervention that's going to work for her. So we're going to do some prompts, some verbal prompts. And maybe we're going to say 2 verbal prompts seems reasonable for her. She's got some psychoses going on. She may be very internally preoccupied at times. So we're going to say 2 prompts to successful shower, okay? Does she need prompting during showering, or can she shower independently once she gets started?
Once she gets started.
Once she gets started, she can probably do it on her own. She's maybe not that functionally impaired because she has some really good baseline functioning. Okay, so that's what we've got short term right now. And she's in the action stage, so what is the likelihood that she's going to be able to engage in these short term? Pretty good. Okay. So how about short term for the substance use disorder? What stage of change is she in? Is it a problem? Not to her. So does she want to really address it? No. Is there a high likelihood that her increased use of benzodiazepines and occasional use of cannabis and alcohol during the times where she can't get her benzos may be contributing to her depression? Yes. And actually, when we look at her lifetime, we can see a pattern of alcohol use related to her depression. So we know that there is a tie based on what she's been able to tell us, both chronologically and historically, and what her husband has also been telling us. So we know that the benzo issue is serious and most likely linked in one way or another to her depression.
So an educational approach might be worth trying.
An educational approach. So education around the links between benzodiazepine use and depression. Okay.
And kind of a review of her own history with them.
Okay. So kind of going back along and seeing maybe if she can put those pieces together. All right. We also know that she's in pre-contemplation, so we can use a little motivational interviewing with her to really help highlight this. You know, what you've told me is that your use of benzodiazepines has really increased over time. And I'm wondering, how has that affected your depression? And help her bring that link together, and then talk to her a little bit about how bad is the depression? Well, it's so bad that you're on the inpatient unit now. And what if, let's just suppose, what if your use of benzodiazepines is associated with that? What do you make of that? And see if that helps give her some movement. But also, we can use motivational interviewing to help her with her increased functioning too. What is important to you? Well, you know, I used to like to get dressed up and go dancing and all this other stuff, and now I can't even seem to get out of the bed to go and shower. She's in the action stage. We can find interventions to help also motivate her here. If we can get some idea of what her thoughts are and her feelings, we know that CBT has worked for her in the past. If we can get her past pre-contemplation to the point where she's in contemplation or preparation, which sometimes can happen pretty quickly with people, a session or two. Sometimes it takes a long time, but sometimes not. So maybe there's a motivational interviewing group that's on the unit that we can put her into. Or maybe we just have someone working with her individually to kind of tie these two things together.
I would suspect she would kind of move along with it pretty quickly.
Okay. So let's say we can get her kind of to the contemplation stage, and we know that CBT has worked for her in the past. We can use CBT here. Let's begin to tie the thoughts and the feelings and the behaviors together. So what are you feeling when you notice that you're wanting or craving the benzodiazepines? And what are the thoughts associated with that use? Do you start planning to use? Do you start imagining what it's going to be like once you have obtained that medication? What are the thoughts and feelings that go around when you realize that you're about to run out? Do you panic? Does that increase your anxiety levels? Does that make you more depressed? Really starting to tie some of these things together using a framework that she's already familiar with. So determining readiness to change is an essential component, because that's how we're going to be able to match our interventions to really where they're at. So the stage of change and the stage of treatment. She's actively participating. She's already on the milieu. So we know that we've got her there at least for a short time. Stage of treatment for here, she's in active treatment. She would really like to just jump right in. Here, she might need a little persuasion, okay? And that's where the motivational interviewing comes in. This approach really helps you to meet the client where they are at. Not where we want them to be at, where we wish they would be at, what we very much want for them to want for themselves to be at. It's where they currently are at. Integrated dual diagnosis treatment, I would highly encourage everyone. There's going to be a training on this, so if you can tune into the webinar when we roll it out, this is a great way to actually provide co-occurring disorder treatment for individuals with severe and persistent mental illness, and it can be used in residential facilities and inpatient units and the like. It's a great framework for...
Will people from the substance use agencies be invited to that webinar as well?
Yeah. And I'm actually presenting it in October to the statewide NAMI conference, so that we can really get more and more people familiar with it.
Staff will be going there.
Okay, great. So these slides, I apologize, they're very, very small print, so I'm just going to read through some of it. So for an individual that's in the stage of change pre-contemplation and the stage of treatment pre-engagement or engagement, the client conflict is typically classified as, I don't see how my substance use warrants concern. I see that you're concerned, but I don't even see why you would be concerned. That's really kind of one of the patient dilemmas in or conflicts in pre-contemplation. So treatment goals, straightforward, establish a working alliance. We're starting at the very beginning, the basics, because we need to just get them engaged before we can have meaningful discussion with them. Increase awareness of the impact of substance use on a client's life. We decided we were going to do that. We're going to start helping them make some connections. Create client doubt about the commonly held belief that substance abuse is harmless. Lead the client conviction that substance abuse is, lead to the client's conviction that substance abuse is having or will have in the future significant negative results. So some of the principles here are establish and maintain rapport, express empathy, develop discrepancy. That's the, you say you want this, but you're behaving in this way, or everything is okay, and yet here you are on the inpatient unit. Help me to make sense of how these two things fit together. Avoid arguments, roll with resistance, support self-efficacy, and remembering that the client is responsible for the change. The stage of change of contemplation, we're in early persuasion. So the client conflict, I can picture how quitting substance use would improve my self-esteem, but I can't imagine ever shooting up again.
I think that was supposed to be
Never, probably. Create ambivalence regarding the need to continue as it is or to change. So this is where kind of that pros and cons can really come into play. What are the benefits of not changing? What are the cons of actually changing? Those are the two places that people get most hung up. Not give me all the reasons to change. They can give you 101 reasons to change. But what are the reasons not to change? Because usually it's there that their maintaining factors can be uncovered. This is just a very basic overview of treatment matching and motivational interviewing and how these stages of change really fit. So I'm just kind of breezing through this because I want to make sure we have time. We can help the client discover intrinsic motivators that can help typically move the client from contemplating change into action. So where are they currently? Where do they want to be? What do they think they could do to get there? Because that's the planning stage, right? How am I going to get there? But right now, where am I and where do I want to be? And is there a discrepancy? How great is that distance between here and then? Again, maintain rapport, role, all of these are very much the same. In preparation, we're in the late persuasion stage. So they call it persuasion as in persuading themselves to actually commit to change. I'm feeling good about setting a quit date, but I'm wondering if I have the courage to follow through. So when I mentioned earlier on that readiness ruler, this is a great place to do some assessment with them. Readiness rulers, you can actually find them online and print them out and have them available. But really when you're talking to people about change, it's important to figure out how ready they are to make the change. Also, how important is the change to them? And how prepared do they feel to make the change? And they kind of give you a rating between 1 and 10. Now, if they give you a 5, you can say, well, why not a 3? So that you can really figure out what is it that they think is helping them be at a 5. We don't want to say, well, why not a 10? Because we want to focus on where the motivation is, not where it is not. So helping them parse through some of that. In the action stage or the early treatment, late treatment phase, the client conflict is staying clean for the past few weeks really makes me feel good, but part of me wants to celebrate by getting loaded. It's still a conflict. Even though they're clean and sober, they're not conflict free. And so to be able to allow them to give voice to that conflict and to talk to them about, you know, what it is. So carry out change strategies. Let's stick to the plan. You've prepared for the action, now you're in action. Let's continue to use those change strategies. Provide support and encouragement to maintain gains that have been achieved. This is where people tend to backslide a lot and frequently because change is scary and sometimes change is not as sustainable as they had hoped it was, and it's a lot of hard work. So we really want to be those cheerleaders, helping them continue to make strides to maintain the change. And reduce the ambivalence about transitions from thought to action. So they're thinking that they would love to go out and get loaded, and yet their behavior is saying that they are really committed to staying clean and sober. So can we talk about that ambivalence so that we can really help give voice to that piece that wants to backslide and still help you move forward in maintaining the changes that you've made? So the stage of change of maintenance, this is really where we're looking at relapse prevention. You've done it, you've got your plan, you've worked your plan, now you're working that plan regularly, it's part of your life. How do we keep you from relapsing? So the client conflict is, these recent months of abstinence have made me feel that I'm progressing towards recovery, but I'm still wondering whether abstinence is really necessary. This is where you have individuals with alcohol disorder saying, I'm gonna just try to be a social drinker. Or, I know bars have been a trigger in my past, but what I'm really going to do is go and have a soda. I've got it all planned out, but it's my friend's birthday and it's really important and meaningful for me to go. So I'm gonna put myself in this really high-risk situation. So working with them on relapse prevention is really key here. Reinforce new skills that help maintain recovery and a healthy lifestyle. And the idea of recurrence. So we want to get help to recover as quickly as possible and re-enter the change process if someone has a relapse or a reoccurrence. So it's the shame and guilt that often come from, unmet expectations of themselves and others that prevent people from re-engaging into treatment. But if we can normalize that recurrence or relapse as part of the change process, the quicker they typically are to re-enter treatment, and the quicker we can get them to do that, the less gains they end up losing. And then treatment planning. So as I mentioned before, the integrated dual diagnosis treatment, this goes through the stage of change, the stage of treatment, and then the clinical focus. They talk about outreach, building the relationship, motivational interventions, skill building, cognitive behavioral interventions, and recovery, lifestyle, social support, depending on the stage of change and stage of treatment that someone's in. These will all be in your slides when they're sent to you. There's a gentleman by the name of Ken Minkoff who really was one of the forefront developers of co-occurring disorder treatment and integrated treatment. So he has a lot of different ways of explaining why integrated treatments really do make sense and why they need to be matched. But the key piece to integration is that an individual really does see that the treatment is seamless, that it's all as one, and that the focus is not on two separate disorders specifically, but the interaction between those two. That is really the hallmark between them. So if you are a cognitive behavioral therapist, you can use CBT for both substance use disorders and mental health disorders if the person is in active treatment. That would be an evidence-based practice that you could bring forward for them. Thoughts, feelings, and behaviors associated with use, thoughts, feelings, and behaviors associated with their mental health issues. If you prefer motivational interviewing, you can use those for both. So evidence-based practices really also include things like case management. We know that case management is an evidence-based practice for individuals with co-occurring disorders. It's not necessarily about a manualized treatment. Even integrated dual diagnosis treatment really talks about the programmatic factors or elements that need to be present in order for integrated care to exist. But it's about collaboration, coordination, communication, and making sure that there is a treatment plan and that everyone that's involved with that individual's treatment is really talking and working together to help move the person towards their goals.
And the particular methodology you're using may shift and change depending on what's happening and what's effective at the moment.
Right.
So the more tools you have, the stronger you are in approaching anybody with these issues.
Absolutely. So I'm just going to highlight this last little statement here. Based upon all of actually what we've talked about over the last 2 days, there's no single correct dual diagnosis intervention or single correct program For each individual at any point in time, the correct intervention must be individualized according to the subgroup. And when we talk about subgroup, that's sort of that SMI, non-SMI, high substance use disorder severity, low substance use disorder severity. That's what we're talking about with subgroup. Diagnosis, stage of treatment or stage of change, phase of recovery, need for continuity, extent of disability, availability of external contingencies, and the level of care assessment. So it really is the entirety of all of those data points coming together to help identify what does this individual need in the here and now. That's it. Okay, so I'd like to just spend a couple of minutes going over what the expectations were when we started this journey together so long ago. Before I do, any questions about that? Because the second half of the day was just a lot of information. Any questions, comments, concerns? Okay. So I'm just going to run through the list, and you can say, yes, we think we've touched on that enough for what I considered sort of that mile wide, inch deep introduction into a lot of these different topics. Or no, if you don't feel like we've addressed it adequately. Ways to integrate co-occurring into programs and inpatient. Yes, no? Is there something that somebody still is looking for? And a hush falls over the crowd. Okay, so we know that addressing barriers is still an issue. We have ideas as to some solutions. You have collectively come up with a lot of great ideas, as well as identifying some of the barriers to being able to implement some of those ideas. So hopefully the co-occurring team at SNAMS will have an opportunity to come to the inpatient unit at some point and really do a much more guided approach to how this could really come to fruition within inpatient. Assessment tools. Do you feel like you've got assessment tools at the ready? Okay, good. ACM locus. Okay, so we touched on it. I will encourage each of you that if there's a locus training that comes up or an ACM training that comes up, if this is something that you feel would really help you clinically, I encourage you to take it, the class, because I think it will really help expand your area of knowledge and understanding here. How about chip away at resistance to change?
That's ongoing.
Yeah.
Ongoing, okay, all right. All right. Co-occurring disorders in the treatment mall. Pending. Okay. Do you have a better idea of how this could be introduced into the treatment mall?
Since the treatment mall is such a new, ongoing, collective thing that's happening, this is probably the perfect time to try to introduce things in before everybody's set in stone, and then we're resistant to change. So
Okay.
timing is probably perfect.
Great. So who's the representative? Who's the representative to bring this to those who are developing the treatment mall?
We already brought it up in the working group.
Okay.
It's been brought up.
Okay.
You know, we're trying to get AA, NA in as well as having a program. It just depends on who's going to do it and where.
And who's going to develop it? I mean, that's always.
Well, I mean, I think that's the easy part. The hard part is who and where. And then when there's not enough room and not enough staff to do it,
Well, that's part of the developing.
yeah, we're just chipping away.
Yeah.
We'll see what happens.
Okay. Co-location, not necessarily integration. Do you have a better idea of the difference between the two now? Between co-location and integration? Everybody feeling that they've at least updated some of their basic information that they came in with? Okay. Communication to increase the therapeutic relationship. Yes? I see some nods. Okay. How to treat and increase outcomes. So we didn't get really into the nuts and bolts of actual treatment, but we talked a little bit about treatment planning, so maybe this is something that we want to look at for a webinar.
And the other part of that is needing to get medicine involved with psychiatrists and doctors. Otherwise, we're talking and it's like, this probably may not go anywhere.
Right. Got it.
You're talking about maintenance,
I'm talking about getting doctors on board with the whole concept, or it's going to go.
Yeah. Outpatient, we have a little bit more latitude. Inpatient is a lot more challenging.
Well, inpatient is so much more of the medical model.
Right.
Yeah.
Yeah. We talked about some of the next steps, including everyone now will have access to that dual diagnosis capability toolkit. You can bring it to leadership. You can talk to your supervisors about it. We can have our team come and work with the inpatient unit to see what changes they're ready, willing, and able to make sooner rather than later. We talked pretty extensively about the no wrong door. How about continuity of care? We touched on it a little bit, but I really see that there is a great opportunity to pull inpatient and outpatient together to really delineate responsibilities and processes around developing a better continuity of care, all the way from treatment plans being translated from inpatient to outpatient to really doing the warm handoff to make sure that there's adequate follow-up after discharge. So still an area to be addressed. Neurological components of substance use disorders. This will be a webinar. So there were some links to articles. There was a NIDA article that was emailed to you, the link to it. So download it and read it in preparation for the webinar, because that will give you a much better background. So that's definitely another webinar. Decreasing rates of recidivism.
We'll see if all this comes together and makes a difference.
Right. Role of nursing in co-occurring disorders. Do you feel like you have a better idea of the various roles that you could play? Simultaneous treatment, so the difference between sequential treatment and simultaneous treatment, both together at the same time is best. Treatment on the acute care ward. We talked quite a bit about maybe ways that you can begin to bring this into inpatient. The public health model, we spent a pretty good amount of time on that. Resources, didn't really talk too much about the resources that are available in the community. Okay, and then the difference between therapeutic and non-treatment. I wasn't really sure what that meant, but overall, how did we do?
We did well.
Okay. All right, so let's prioritize. Some things are really not necessarily going to be ideal topics for webinars, but others might. So I'm wondering if, these two kind of stick out for me. So treatment, actual treatment modalities, evidence-based practices for co-occurring disorders and how that feeds into the continuity of care, and the neurological components of substance use disorders. Does that sound reasonable to you? Yes? Okay. Yes. And so really what we discussed over lunch and what we're doing at the rural clinics to help people become co-occurring capable by June 30th is meeting with each clinic, their clinic director, and going through that dual diagnosis capability toolkit that we touched on yesterday in detail, and engaging them in what's really more of a self-study or self-assessment process. And then they are the ones, each clinic is responsible for identifying what their action plan is, and then identifying any additional needs, training, technical assistance that they may need in order to be able to get there. There are also, like I said, items on there that they can't necessarily directly affect change on, and we've got a pretty good grasp on those. So now it's about making sure that the message gets out that those are addressed at a leadership level. All right. That's all I had for today and yesterday. So I want to thank everyone for paying attention and participating, and it's been great. So thank you.